So it's now my great pleasure to introduce our keynote speaker, Dr. Paul Farmer. Many of you know his work. Paul is a medical anthropologist and physician who has dedicated his life to improving healthcare for the world's poorest people. He's co-founder and chief strategist for Partners in Health, the highly respected and influential international nonprofit organization that since 1987 has provided direct healthcare services and undertaken research and advocacy on behalf of those who are sick and living in poverty. Paul and his colleagues in the US and abroad have pioneered novel, community-based treatment strategies that demonstrate the ability to deliver high-quality healthcare in resource-poor settings. He has written extensively on health, human rights, and the consequences of social inequality. His message tonight and the key themes that he touches on will resonate in the meeting rooms, in the hallways, and during the discourse throughout this week. Please welcome Dr. Paul Farmer.
Thank you. These blinding lights mean that I don't have to be anxious since I can't see any of you. It's a real pleasure to be back at this nice people meeting. Some time ago I gave a talk at these meetings about the history of colonial medicine and therefore our own roots, but no buts, period. Thank you for those who are chuckling. If there was ever a professional society, medical society that has embraced the equity agenda, embraced inclusiveness at scientific meetings, embraced trainees and students. I understand a third of us gathered here are trainees or students. I can't think of any other, and it is an honor as ever to be a member of this society and to be invited to speak. I was invited by Patricia to address this topic. I took you quite literally, the failure of imagination. And it's easy to say, she already busted me that I am an anthropologist, which is a highly scientific discipline. You get a PhD just by schmoozing with people, which I think is terrific. You learn a lot by listening, of course, and you're supposed to do that in clinical medicine. I just want to think a little bit about how we re-socialize our understandings of tropical medicine without going back on a historical tour, and underlining, as Patricia already did, the moment that we're living now in terms of climate, in terms of political instability, in terms of movement of migrations across national borders, and in terms of global health, which is different from global health equity. This is when I reached southern Haiti, and many people here in this room have spent time in Haiti, it looked to me like this hurricane-struck part of Haiti, again, had been torched, or it reminded me a little bit of the earthquake in 2010. And the difference was, of course, that the larger concrete buildings are the ones that fell during the earthquake, and the little shacks and with tin roofs or sometimes thatch roofs were too small to fail. But that's not what happened when Hurricane Matthew sat on southern Haiti for days with 140-mile-an-hour winds. One woman explained to me that they had lost their roof first, and then they sought shelter in a concrete house, and then, as she put it, their chickens exploded. And, again, listening to people, it just would not have occurred to me, my last name aside, that livestock, even medium-sized ones, would be killed in a storm like that. And in spite of climate change deniers, we know that this is the result of, I'm not saying this particular hurricane, but we know that extreme climate variation is related to human activity, and that's another kind of resocializing activity. And I want to focus a little bit on, I'm just going to focus on Ebola, because I suspect that Dan Bausch was also behind my invitation back. Where did he go? Somewhere. Oh, there you are. I should have seen the shine. He's a good friend, so I'm allowed to. Was a good friend, he just said. I'm also grateful, of course, to have been given space in the journal to think about resocializing epidemics. This one was about cholera. And the general point that I'd like to make, which is not new, but it keeps recurring again and again, is when we have scientific progress, which is largely the fruit of basic scientific research. We have new preventives, they may be vaccines. We have new diagnostics, many of them molecular, or relying on molecular platforms, and we have new therapies. And we fail every time to pull together an equity plan. And so, as Louise Ivers, who was honored by the Society the year that we wrote this together, she's at Harvard and Mass General, as a couple of my friends from Mass General are here tonight. When cholera struck Haiti, it was the same tired logic that comes largely from development economics. Again, that highly non-ideological and technical field. Thank you, Michelle. And those arguments sounded like this, and they'll be familiar to anyone who's worked as a clinician, that a new development is not cost-effective, not sustainable, not feasible, not a priority. And that logic has its place, but it has now come to overwhelm, and has now for at least 2 or 3 decades, overwhelm other kinds of logic, including the equity logic that Patricia just laid out in her opening, or in her welcome. And in this particular instance, and some of you know the story, one of my classmates from medical school is a cholera expert, and he's here tonight. There was a vaccine that hadn't been around the last time cholera made its world tour. I happened to have been there for the tail end of that American pandemic, which ran up and down the coastline of South America. I was working in Peru, across the Caribbean. It was a very similar story. It somehow seemed to have spared Haiti, raising questions of immunologically naive populations, and exploded there. And many people believed that that was because of the earthquake, but that is not the case. In fact, the earthquake-affected zones were among the less affected by cholera because people were in camps and drinking purified water. The most vulnerable populations were rural areas not affected by the earthquake. And I know this because it's ripped right through the area of Haiti where I've been lucky enough to work for 35 years. A humiliation in a way, right, for our work, because although we could drop case fatality, which is nothing to dismiss, there was no way to make up for an absence of long-term and sustained, not sustainable, sustained investments in water and sanitation. And the way this translated was, again, now we have to focus on sanitation, so let's not get distracted by uptake of this new vaccine. It started immediately, whereas the cholera vaccine, the new cholera vaccine, had already gone through trials, had already been shown to increase herd immunity, and already been shown to decrease the size of and the mortality of epidemics in a number of settings in the world. And again, people in the society have been involved in that research and in those trials. And that is not the reason, but it is among the reasons that this epidemic went completely out of control, exploding like a bomb across first central, then the Artibonite regions of Haiti, and then the rest of the country. And 1 million people were thought to be afflicted within a few years, and 6,000 died in the first year. Unprecedented mortality, alas, unprecedented in the Americas, and has caused a number of ongoing political and social problems that might have been lessened, at the very least, by gung-ho efforts to introduce new technologies, not as a replacement for the basic investments in water and sanitation, but as a complement to them. Now, does this happen again? Okay? Everybody who's an anthropologist, and by the way, I am a proud one, I'm not mocking my discipline. It's still hard to write those books. Context matters. right? Too obvious to say. But look at some of the commentary you have heard about the Ebola epidemic. And I'm not talking about the commentary of scientists, although one wonders where these ideas came from that were so widely echoed in the popular press. And by popular press, I mean mainstream press. Context matters, obviously. That was the example I gave. The first picture is in Haiti after the earthquake. The second is a recent photograph that was in the Wall Street Journal from a town where we started working in Liberia, Harper, the capital of Maryland County. And some people here have been there. It's in the far southeast, and it had been a hub of development, even a vacation resort for affluent Liberians. And this is what it looks like now, still. It looks like the war was over just last week. And that's because the investments that were required, not to rebuild homes, but to rebuild or build for the first time a health system, were not made after the wars ended there. In Sierra Leone in 2001, 2002, and in Liberia a few years later. Now, why Guinea? Well, Dan Bausch has explored this in one of the most thoughtful papers that I've seen in the journal, or that I've seen anywhere. And that is, if you look at Guinea, the same sorts of ecological pressures exist. And the war affected Guinea in very direct ways. A quarter of the population of Sierra Leone took refuge in Guinea. There were camps like this all over that part of all over that country. And the region where Ebola was held to have started was also profoundly disrupted over long, even centuries. And there's ample documentation of the various extractive trades that have reduced not just the forest, but stability and given way to kind of conflict that you saw most explosively in Sierra Leone and Liberia. So when someone asks, well, why those three countries and no others? Because Nigeria, Mali, Senegal, Spain, the United States, secondary transmission occurred there, but it was nothing compared to the epicenter, which was largely constrained to these three countries. Just remember, as Dan Bausch said in his piece, that's where Ebola, and many other pieces I should add, that's where Ebola epidemics occur, after conflict and without a health system that is able to diagnose and respond to at the same time an affliction. Now, just to go talk a little bit about this, zoonoses that pop out of forested obscurity and reach urban areas are old news in our field. And just these first two, are the filoviruses, Marburg and Ebola, are increasingly well-known and certainly well-known here. But HIV has a similar story. And each one of them, of the Ebola epidemics and the Marburg epidemics, have been characterized by disease that's transmitted through caregiving. This is a caregiver's disease. And that's true whether you're talking about traditional healers, as they're called. In a clinical desert, people will always seek care. And if there aren't physicians and nurses, then they will seek it from anyone else. But the majority of care, even for acute illnesses, is delivered in families. And the last act of caregiving, you don't have to be a Catholic to believe this. In fact, most people in Sierra Leone are Muslims. The last act of caregiving is burial. And my grandmothers would be very proud of me standing here and remembering one of the 7 corporal works of mercy is to bury the dead. There's no society that's well described by anthropologists or anyone else where this isn't the case. It was very much the case in the United States until it was outsourced at the beginning of the 20th century to a very expensive profession. As for kissing and touching corpses, I'm getting on in age, but I can tell you that when my father died, it's exactly what Catholic families did and maybe still do. These are not the exotica that reach the popular press in accounts of why this explosive epidemic did reach cities. If you're an infectious disease doctor, and this is kind of what we do, No offense, but we like to show off with long lists of differential diagnoses. But really, fever, diarrhea, nausea, vomiting, it could be anything. Choleric presentation of malaria. The malariologists here will know that that's in every textbook about malaria. And we don't even use those terms anymore because we have better diagnostics. And the more they're deployed, the less we have to talk about clinical patterns that may give a tip to clinicians. But basically, this requires staff, stuff, space, and systems. And the space means laboratory capacity, and as again, Dan has pointed out, as regards Ebola. And the stuff, the tools of the trade, which must include tools for caregivers, right? To have a research capacity alone or a diagnostic capacity alone, people don't come saying, what is my diagnosis? They're saying, what is my diagnosis and what is going to happen and how do I avoid that fate? And indeed, that is what happened in West Africa, Upper West Africa, from 2014 in the year that followed. So staff, stuff, space, and systems, if you have one bit of this without the other, if you have the staff but don't have laboratory capacity, if you have laboratory buildings but no diagnostics and supply chain, if you don't have systems, meaning in this case infection control, you're going to see nosocomial and lab-based transmission of these pathogens. And I say these pathogens, I'm not talking about filovirus, but communicable pathogens. And a lot of my work has been on tuberculosis. It's the same story there. It is a caregiver's disease, but it's airborne and of course has a different pattern of spread. And more likely to blanket a household or a community, especially the lung blocks of the early 20th century in the United States. But Ebola, again, is strikingly patterned as a caregiver's disease. Now, to go to a couple people we've honored here before, and one of them, actually a number of people here are friends with at least two of these three, and some of you will know the third who came to the meetings, I think, last year. These are three of the four Sierra Leoneans I knew. First time I went there in the summer of 2014. I'd never set foot there. It was for a surgical conference. I have had surgeons say to me many times, well, you're an infectious disease doctor and you're interested in surgery. First of all, I'm interested in what people need, and surgical care is usually part of that, even in infectious disease. But in other words, we shouldn't allow our professional training to confuse the matter, especially when it involves a near absence of staff, stuff, space, and systems. And it's worse now. Two of these three people participated in the fourth one as well in that surgical conference, and that's because only one of them, Martin Salia, in the middle, was a surgeon. Two of them were. The other one isn't pictured. They wanted to see their country become less of a clinical desert, and a clinical desert that is a public health desert as well. And by November of that year, again, as Dan has said in his beautiful paper, two of them were dead of Ebola, Martin Salia and Humar Khan. Now, what did we hear in the popular media? Turns out, by the way, that the President of the Republic now, the United States, tweeted 102 times about Ebola. I didn't know this because I was with my colleagues in West Africa. Let's just say very few, if any of them, were kind-hearted. And some of them were directed against clinicians, including at least one of these, but also Americans returning from service in Guinea, Liberia, Sierra Leone, or anywhere near them, you know. And Dan has some stories to tell. He'll give me a green light one day to share some of them about the meetings in New Orleans. I love New Orleans. Can we go back there, Dan? Yeah, I know. But I'm actually trying to make myself smile because this is a painful topic, I'm sure, for many of you. But the cover of Newsweek, which you see in the corner, I think appeared after Humar Khan died on July 29th, along with a great number of the nurses who had worked with members of the society, including Dan. That's not what this was about, the Exotica. And historians of epidemic disease and anthropologists have a heyday, but usually some years too late, talking about the way in which epidemics on that continent almost invariably are exoticized in this fashion. This is the paper that I referred to, Dan's paper, and it is, I believe, the most honest assessment of some of the things that went wrong in the middle of that epidemic, at least as concerns Sierra Leone. And I would encourage everyone to read it. But there was laboratory capacity. It was the only place not too far across the border from Guinea where you could diagnose a hemorrhagic fever, 2 of them, Lassa and Ebola. But the epidemic was hidden away until, I believe it was May 25th, when the first 2 cases in Sierra Leone were diagnosed by laboratory capacity. It turns out that by March, the World Health Organization and the Ministry of Health of Guinea had already documented a number of cases in Sierra Leone just by tracing the movements of patients with known or alleged cases of Ebola and connections to what was held to be patient 0. Again, a dubious construct, but one that did make the papers. A research lab alone, however, does not give you the staff, space, and systems that are required to respond to a caregiver's disease and to provide what people are after, which is care. And that would have been true in the United States, that would be true in Europe, that would have been true even in Berkeley, California. I'm kidding. It was the same story with non-professionals. They were caregivers too. These are 3 of, these people have become my friends. There's another survivor there, and again, these are people who have been included in a number of meetings organized by Dan, by Ian Crozier, and I don't know who else from that crowd is here. These are all Sierra Leoneans. The nice portrait with the 3 people is a classic enough story. The young woman with the pink, ever since radiology, I cannot tell left from right. The young woman where the right lung would be. Her grandfather was a traditional healer. Her father, they were living in Freetown, she and her father were living in Freetown, as many people did have after the war. Her father's father was a traditional healer, and he was out in a rural area. He got sick, his son went to care for him, buried him, came back to Freetown, he got sick. Her best friend, where the left lung would be, helped her take care of him, and her partner helped bury her father. Then they all fell sick, and their baby died. The other fellow with the plaid shirt, his name's Ibrahim. I remember a very striking evening. It was at the height of the. You gotta have some levity in this, or I get slowed down. We don't get choked up at the society meetings, but it was at the height of the Western surge, as it was called by many epidemiologists, as the disease went from east to west. As Freetown and Port Loko became the epicenters on the epicenters of the epidemic, we started, even in October, having survivors meetings. And we would have dinner for them, we still do. And some people said, well, you can't have dinner for Ebola survivors at the Radisson. Which I said, oh yeah, you watch. You have a credit card or cash, no one will object. And they have not. And the last one of these folks that I met in the picture there is a young man named Ibrahim. And I hadn't met him, so I got to sit next to him. This is, again, in late November of 2014. And he told me that he had lost 22 members of his family to Ebola. And I didn't know what to say. What kind of infectious pathogen kills 22 members of a family? There are not a lot of them. And I'd spent a lot of time with him in the years since then. And I got up to 21, and I'm sure I'll find out, kinship being complicated even for anthropologists in this part of the world, I'm sure I'll find out who the 22nd was. Devastating impact, again, as a result of the lack of a healthcare system. And there was a chance to rebuild the healthcare system, and it happened after a catastrophe. And that wasn't Ebola, that was war. And now maybe the window is closed, but there was a chance to do it again after Ebola, when the world's attention settled fitfully and shortly on the epidemic. One of the best ways to look at equity as a tropical medicine, the only reason I had quotation marks around tropical medicine is because latitude is not the primary determinant of where tropical diseases occur. Malaria was across the Mississippi region, way up north. Boston had cases of malaria. It's really about poverty as much as anything. I mean, there are exceptions, of course, and we all know what they are, but they're really tropical diseases are tied as closely, as Patricia said, to poverty and migration and displacement. One of the best things to look at is case fatality, right? Of those who fall ill with an illness, cholera, drug-resistant tuberculosis, HIV disease, you pick your poison, Ebola, Marburg. Looking at who lives and who dies is a second chance to think about equity. Dan, the paper of the subtitle of Dan's paper was "Missed Opportunities for Prevention," and he describes very clearly that he means preventing deaths as well. The more these Ebola treatment units had no T in their ETU or too little, the more likely it would be that people would flee them. And indeed, they received amazingly discrepant, confusing messages from experts in health education, who again got some of their information from experts in the field. Looking at Marburg, which in its 1967 debut, as you might imagine, it was called Marburg because it was discovered in Marburg. And why was it discovered? Because they had the staff, space, and systems in order to identify a new pathogen. Those were absent from the continent from which it hailed, right? But case fatality in 1967, without knowing what was going on, was obviously empiric and focused on symptomatology. Sometimes people were losing 10 liters of fluid a day. Ian Crozer, who may be here, I hope he's here, he was losing 10 liters of fluid a day, right, at some points during his illness. How do you care for someone? Well, they managed in 1967 in Hamburg, and I believe also across the border in Yugoslavia, to have a case fatality rate that, though horrific at 23%, was and remains radically different from what we see with Marburg epidemics on that continent today, meaning not Europe, but Africa. And that's a good way to look at how we're doing, because there's never going to be a metric by which to judge our success that's based only on publications, on new discoveries, on developing new tools. It's always going to be based on how useful those are deemed by those most likely to endure these illnesses. So after Ebola, if we are after it, and again, I think somebody living with its sequela would question that diagnosis of after, we still failed to focus on health systems, we as a collective we. And Sierra Leone already had the highest maternal mortality in the world. And these are, of course, projections, but there's no question that whether you look at outbreaks of new pathogens, case fatality of people who were once in programs to treat tuberculosis or HIV, or just the course of obstructed labor, right? You're going to see a worsening in terms of performance because, just to give you one number about staff, 211 of Sierra Leone's health professionals died in the course of the epidemic, Kumar Khan and Martin Sali among them, but 211. And you do the math on how many were there to start with, and who wants to work in a place like that without the staff, space, and systems? And I know I couldn't take it, not for long. And so that work, whether we're focused on basic science research, on developing new tools, or on delivering clinical services, that work, or just as taxpayers, right? That work requires an equity perspective, just as responding to Haiti did. The numbers that you read about pledges This is particularly grievous for citizens in these countries because these numbers come from pledges made in international pledging conferences. I had already learned the hard way about them. That doesn't mean that these pledges will ever be dispersed or that they are new money for Ebola. In fact, nobody usually tracks them at all. This happened after the earthquake in Haiti as well. During the epidemic, that is the time of active transmission, less than a quarter of all these pledges ever made their way to any kind of meaningful transfer, and that doesn't account for implementation. So these patterns that we see again and again after hurricanes, and I'm finishing up, after hurricanes, after so-called natural disasters, right, and after explosive epidemics, which will happen more often in the future, they're usually the same ones. We don't think about health system strengthening. We don't think about training personnel. We don't think about strengthening national institutions. And that has been the tragedy in West Africa as well. It doesn't look, that I forgot to say in one of the slides that, that this was, I did say this was a ward at Kenema Government Hospital, but it was just as bad or worse in parts of Liberia that I saw. This was supposedly an Ebola isolation unit or a community care center. And nobody would go in there except to die, which is why no one ever did. The district health commissioner, who was a very fine person, a nurse who said, well, we're an Ebola-free district. And I didn't say in Zwedru, Liberia, what I was thinking. I did later because she came to Harvard, that it's a lab-free district. So how would you know? How would you know if there's Ebola? How would you know if there's Lassa? Without a lab, you cannot tell. And this is not the way to proceed. After the earthquake in Haiti, we were granted, I had a chance to talk about this already, but we were granted a reprieve from this logic as partners in health because we received unsolicited donations, a very substantial amount of money, and we got to make our own decisions with our Haitian colleagues. That didn't happen with Ebola, if I'm not mistaken. Right? More than half of all American households donated to earthquake relief. This is the nursing school, by the way, after January 10th. You can imagine that none of the third-year nursing students who were in session survived, and neither did their faculty members. Right? So it's the same set of problems, perhaps on a less dramatic scale in terms of loss of personnel, but 20% of the Ministry of Health employees in Port-au-Prince died or were maimed in that one episode. So it called for rebuilding the capacity to train Haiti's nurses, doctors, health managers, allied health professionals. If anything did, it was the earthquake, which its epicenter in the city, which took out the major teaching hospitals. Actually, you can see part of the general hospital tottering over the nursing school right there in the corner. And so we proposed, and the we here was the Ministry of Health and our partners in Haiti, building an academic medical center. And this was scoffed at by experts in public health development and disaster relief. Now, I can get disagreeing, but scoffing is an absurd reaction because if not then, when, right? If you wouldn't invest in rebuilding academic medical centers after they were destroyed in an earthquake and build them outside of the earthquake zone, when would you do that? And I would argue that we're at a similar juncture in Upper West Africa in those three countries. This is the medical center we built. It's been open already for years. It's trained a large number of, the largest number probably of Haitian physicians and nurses and allied health professionals. It is that empty spot now has a BSL-3 lab. I told some of you we were going to try and do it. It's not going to be easy to run, right? We need staff, space, and systems. But again, if not now, when? The other laboratories aren't functioning. And to do this without adequate clinical care is something that would not be possible in the United States, at least not since the Flexner Report in 1910. Before that, you could get a medical degree, even at Harvard, I believe, without ever working in a hospital. But that's not how our colleagues in Africa or any other place that I've been wish to be trained or could possibly be trained. And so some of those resources that are targeted to training the trainers and weekend workshops or having them look at PowerPoint presentations for a couple of days. It's a nice break for us here, but it doesn't work if there are no formal training programs. Now, I want to end on a positive note, although you're thinking, how is he going to do that? I am an optimist because I've seen how much can be done in a relatively short amount of time in many of the places you work and many of the places we work. I've also seen, as the society has, the caliber of people who we bring from those 100 countries, young people particularly. And we have every right to be proud and to listen when they tell you how they were trained, which is very similar to how we were trained. They went to medical schools, they went to nursing schools, they became basic scientists, but it's a very hard row to hoe on that continent because of the lack of commitment to higher education and robust health systems. Now, Martin Salia and Humar Khan are not with us anymore, but a number of you in this room have started funds in their honor to keep their memories alive, and others as well. And I would just encourage you, and I hope I have the blessing of the society to mention this, I would encourage all of us to support these efforts, in part to address the emptiness that was left behind, but also to, again, honor the memory of these men and so many other men and women who did not survive Ebola. Thank you for allowing me to speak here today. And again, I hope I didn't end on a sour note. We're just beginning to see the impact of integrated efforts to promote research, training, and service delivery in the places who need it most. Thank you very much.
So, Paul, thank you so much. And
on,
I
fun
think,
person.
and he is a fun person, by the way. I think it reminds us to always have in the conversation discussion of poverty and equity and health system strengthening, that no matter whether or not we're a bench scientist or someone who's in the clinical world, we have to keep talking about poverty and equity. So thank you. We do have a gift to thank you for this evening.
Thank you. Oh, that's lovely.
Yeah.
Thank you.
Thank you.
You have to get in this picture. I never lose these.
Yeah, thank you.